to World Brain Day on July 22nd. We're speaking to patients, clinicians, and neurological charities in relation to their experience of COVID-19, what it meant for them, and what they believe it holds for the future of neurological care services. This afternoon, I'm delighted to be joined by Professor Orla Hardiman. She's Professor of Neurology in Trinity College Dublin, and she's also the clinical lead for the National Clinical Programme in Neurology. Thank you for joining me, Professor Hardiman. Can I ask you first, what's the situation at the moment in relation to the reopening of neurology services?
The situation is that most centres are back up and running, albeit in a different way from the way we ran beforehand. So the limitations are, I suppose, we start in terms of waiting lists. We've had a very significant increase in the number of people waiting for appointments. And although my colleagues have worked really hard during the epidemic to try and keep people well and in their homes by engaging in innovative solutions such as tele-linked services and going out of the way to ring people and also to be available by telephone consultation, that we still have waiting lists that have increased because some people just need to be seen. And we're limited because of social distancing now. So the number of people that come into clinics has to be reduced, obviously, and we can't have people sitting in the waiting area anymore. And some centres have had to actually move where they do their clinical consultations. So, for example, in Cork, they've moved to another building, in a converted convent, actually, from the hospital setting. So that's been problematic because it means that the number of patients that we can see is lower. And then it has a big impact on multidisciplinary clinics because in a multidisciplinary clinic, we normally have people coming in and the various different clinical professionals are available, but there is a waiting time for people to be seen by the clinical professionals. So that's a challenge because it means that people are waiting in the waiting room for longer than they should be if they come in, but we try and limit that. So there's been a bit of a reduction or drop off from that point of view. Having said that, there's a lot of innovation and solution finding within the system that is trying to mitigate these issues. There've also been delays in other aspects. For example, things like intervention, so giving people Botox for spasticity, putting tummy tubes in for people, neurological investigations, imaging, all of those things have been delayed. So we've got a bit of a backlog in all of those areas. We've calculated that actually, so we know across the country where the delays are. They're worse in some areas than they are in other areas. We also had a bit of a problem with redeployment. So some of our teams were redeployed during the crisis, particularly our clinical professionals. The HSE was good in recognising that the clinical nurse specialists should not be redeployed. That was pretty much the case. We had a little bit of redeployment there, but those nurses were by and large left alone. But some people were redeployed. So we're having some difficulty still with people who've been redeployed coming back into the system again, and backlogs from that point of view as well. And of course, there's illness as well. And people, some people got sick during COVID, so we have still have some people who are out because they became ill during the epidemic and are not back in service yet.
Okay, and what do you think the next couple of months holds? Do you think these are problems that will iron themselves out, or do you think there are real challenges ahead for patients and families in what to expect from neurological care services?
I mean, I think no more than any other subspecialty within the health system, there will be challenges, and there are challenges. One thing we should say, I suppose, is that for people with neurological problems, I think that neurology did better than a lot of other disciplines during the crisis for a couple of reasons. One was that the neurological patients are lucky in that they have, by and large, good, strong voluntary organisations under the umbrella of the Neurological Alliance. And I think that made a big difference. For example, MS Ireland had a really good communication strategy during the crisis about the risks that people with MS might incur by being on treatment for their condition. And many of the other organisations were similar. The HSE itself had a really good website as well, or has a really good website with information on it about particular risks within particular groups. So I think that going forward, where the problems are still there, we still have the backlog of patients who haven't been seen yet. That's gradually working through. Most hospitals are engaging now or investing in telelinked services. There's an encouragement to undertake video calls where possible, or at least telephone calls. So a lot of us are trying to maintain services with good quality telephone-based contact. The best type of contact is video linking. That's quite variable around the country. People over a certain age may not use smartphones or may not have access to broadband, and that can be problematic. Most hospitals, I think, have teething problems in this regard, and I have myself as well, using the system that we have. So I think there's going to be a big learning curve for all of us in what's okay to do by telephone call, what's okay to do by video link, and what needs to be seen. And I think we need to work through that. There will be a need to, I think, follow the aspirations actually of Sláintecare, which is that we try and ensure that when people come to hospital, that there's a very significant added value in that, especially if people come to major centres, and that if the service can be delivered locally with innovative outreach, that's what we should be doing. In order to do that effectively, though, we have to have good centralised hubs and good outreach programs. So it's uncovered limitations in that regard, and a bit of geographical disparity that we really need to work on. So if we're going to do a sort of Sláintecare model where we've got good hubs and very good coverage around the country, then we have to pay attention to the parts of the country that don't have good hubs. So we have really good neurology in Sligo, for example, but grossly underfunded in terms of the delivery of care that it needs to be doing within the community. So Sligo is covering all the way up to North Donegal and right the way across Mayo, but there are only 2 neurologists, and their specialist nursing services are limited. So those sorts of things we need to address. Similarly for Limerick, which has the makings of a very good hub, but is still underfunded. Southeast is a bit of a disaster because we have really good neurology there, but very poor integration of services. So I think what COVID is going to uncover is that very significant geographical disparity, and that's probably going to make that worse unless we invest in it. So I think we need to really pay attention to that. That should be a combination of good resourcing, really good specialty services, developing specialist nurse, but also building out a program of advanced nurse practitioners, and that is something that's within the framework for the HSE, but we need to, I think, fast track that, and there's great scope for doing that within neurology actually. Neurology also has a Sláintecare funded program in migraine. Now that was put on hold during COVID, and we're hoping that will reactivate sometime in the second half of the year. But we've had to reimagine how that's going to look, because a lot of that was involving group work and face-to-face meetings. So we've had to reimagine that as online group networked programs, so that we're in the process of doing that now. So I think a lot of change is going to happen, but we need to make sure is that as we implement these changes, that we don't lose quality in the delivery of what we do, and that we're very conscious of the risks of exacerbating the geographic inequity that we already have.
Okay, perfect. And just finally, in 1 or 2 sentences, what do you feel the learning from COVID has been for neurological care in particular?
I think you need a crisis to reimagine how care can be delivered effectively and efficiently. And I think for us, we're a good integrated group. Like the neurology service works very well, and I think that we're a group that can learn from COVID in reimagining what a really good integrated service can look like in the context of Sláintecare. And I think we should be probably one of the pilot innovative disciplines, that one of the vehicles through which Sláintecare can show what it can do. I think we should be one of the groups that can do that, because I think we've already demonstrated through the epidemic that we've been able to manage well. We've been able to look after our patients well, and we can imagine what it's going to look like in the future. So I think Sláinte has taught us, or sorry, COVID has taught us that Sláinte care is where we need to go.
Perfect. Professor Hardiman, thank you so much for talking to me this afternoon.
You're very welcome.